The serum creatinine is influenced not just by glomerular function, but also by tubular function and the generation of creatinine. Thus, it tends to underestimate the degree of renal dysfunction because as the glomerular filtration rate falls, creatinine secretion increases, minimizing the rise in serum creatinine upon which the glomerular filtration calculation is based. Also, the serum creatinine may not rise for several days after tubular injury has occurred. Changes in serum creatinine do reflect change in glomerular filtration rate, and they are therefore valuable in making the diagnosis of acute kidney injury. A fall in serum creatinine is an indicator of renal recovery from acute kidney injury and correlates with long-term outcomes, whereas such a correlation with biomarkers is not clear but is being investigated. 4. Non-oliguric renal failure, defined as a rise in creatinine with a urine output more than 400 ml day, is the most common form of acute kidney injury and may occur after an uneventful operation in a patient with pre-existing renal dysfunction or risk factors for its development, and occasionally without any precipitating factors. This condition usually reflects less renal damage and is associated with a mortality rate of about 5 to 10%. Most patients can be managed by judicious fluid administration, hemodynamic support as indicated, and a high-dose diuretics to optimize urine output while awaiting spontaneous recovery of renal function. 5. Oliguric renal failure. Oliguric renal failure may occur in patients with varying degrees of reduction in glomerular filtration rate, but when the urine output is below 0.3-0.5 milliliter kilogram hour for 12 to 24 hours, the patient is in the second and third categories of the refill system with a greater likelihood of requiring renal replacement therapy. As noted, once this is necessary, the mortality rate approaches 50%. This mortality rate has not changed much over the past 10 to 15 years, despite the early institution of various forms of renal replacement therapy and general improvements in postoperative care. This reflects the higher risk population undergoing surgery and the morbidity of conditions frequently associated with renal failure, such as low cardiac output states, respiratory failure, infection, and stroke. C. Etiology of postoperative acute kidney injury. First, in patients with pre-existing renal dysfunction, the complex effects of extracorporeal circulation will often induce some degree of acute kidney injury. Mechanisms include renal hypoperfusion from low flow, low pressure, non-pulsated perfusion with hemodulation and hypothermia, as well as an inflammatory response that may maintain afferent arteriolar constriction. Hopefully, utilization of the numerous steps delineated on page 597 to 600 will be successful in minimizing the intraoperative insult. Most patients will recover back to their baseline renal function if no additional insult occurs. However, in the early postoperative period, the most common cause of a further renal result is a low cardiac output state. An additional contributing factor is intense peripheral vasoconstriction, often related to use of alpha agents. Oliguria, occurring as a consequence of reduced glomerular filtration rate, is most clinically significant early after surgery when fluid overload and hyperkalemia can lead to pulmonary and myocardial complications and impair recovery from surgery. 2. The kidneys have a tremendous capacity to auto-regulate and maintain renal blood flow, glomerular filtration rate, filtration fraction, and tubular reabsorption in the face of reduced renal perfusion pressure. Intrinsic renal mechanisms that maintain autoregulation include a reduction in afferent arteriolar resistance and an increase in afferent arteriolar resistance. However, when a low cardiac output state or hypotension persists or patent vasopressor medications are used, these compensatory reserves gradually become exhausted, filtration reserve is exceeded, and endogenous or exogenous vasoconstrictions increase afferent arteriolar resistance, resulting in fall in glomerular filtration rate. At this point of prerenal azotemia, oliguria may occur, but tubular function may still be intact. Aggressive management to optimize renal perfusion at this time is essential to try to avoid tubular damage. 3. However, a more protracted period of ischemia will eventually cause structural tubular injury with sloughing of cells that may obstruct the tubules with back leakage of fluid into the circulation. Impaired sodium absorption and increased sodium concentration in the distal tubules polymerizes proteins contributing to cast formation. There is also an oxidant injury and inflammatory phenomena that result in further hypoperfusion and damage to tubular cells. Some of this damage is reversible, and some results in apoptotic cell death. The term acute tubular necrosis has commonly been applied to this condition. Also, it is a somewhat misleading term. Therefore, it is more commonly referred to as acute kidney injury. 4. It should be noted that an acute ischemic renal insult is a hypoperfusion injury that may be undetected in a normotensive patient. If autoregulation is impaired, the kidney may be more susceptible to lesser degrees of hypoperfusion. Factors to consider are renal arteriolar disease, notably in elderly patients and those with hypertension, chronic kidney disease, or renal artery stenosis. B. Failure of afferent arterioles to dilate appropriately. Non-steroid anti-inflammatory drugs and COX-2 inhibitors decrease prostaglandin synthesis and allow endogenous vasoconstrictors to act unopposed. Sepsis and liver failure increase afferent arteriolar vasoconstriction. Use of vasoconstrictor during a low output state, which tend to reduce renal blood flow despite achieving systemic normotension. D. Failure of afferent arterioles to constrict, noted with ACE inhibitors, angiotensin receptor blockers, or renin inhibitors such as aliskiren. Systemic venous hypertension, often as a result of right ventricular failure, tamponade, or an abdominal compartment syndrome, which may reduce renal perfusion. 5. The acute development of oliguria and the rising serum creatinine several days after surgery should always raise the specter of cardiac tamponade. The combination of systemic venous hypertension and a low output state can compromise renal perfusion even if hypotension is not evident. The patient may have non-specific systemic symptoms, and the compensatory tachycardia may be absent with the use of beta blockers. 6. Conditions of impaired oxygen delivery, profound anemia from bleeding, hypoxemia from respiratory failure will contribute to renal ischemia in conditions of borderline hypertension.